Okay, hello everyone. I'm Dr. Kim, and nice to see you again. And how are you? How are you doing? I know it's not easy for everybody, right? In the world, it's not easy to handle anything right now. But still, at least we have connected, right? Through the YouTube. So GAO and you are connected through the YouTube. At least that's nice to have. Okay, so easiest way to connect or continue our relationship between GAO and you is subscribe this channel. Okay, so I think that you can do it before you leave. Okay, so today I'm gonna speak about workflows, like various digital implant restorative workflows. So it's about something digital. So what do you think digital is? Okay, so in the industry, they are divided 3 steps for digitalization. Okay, so digitation is the first step and making any data to the digital. So for example, if you are using intraoral scanner to scan your patient's teeth, that's the digitation. Okay, if you use those data to the CAD software, that may be a digitalization. Okay, so here the digital transformation is something about automated things. So we are in between digitalization and digital transformation in digital dentistry. Okay, so let's talk about a little bit about the terminology, what we have. So ACP, American College of Prosthodontists, released the GPT-9, Growth Theory of Prosthetic Terminology 9, 2 years ago. According to them, this is anyway recent update from the ACP. According to them, digital denture is non-standard. So we should call digitally fabricated denture instead of digital denture. Also, the digital impression, maybe you can imagine when we use the intraoral scanner instead of making impression, that they said it's a slang. Because English terminology, impression is making something negative likeness. But when we do the intraoral scan, we don't make negative likeness. We just scan the outer surface, right? So I think it's better to call the intraoral scan instead of digital impression. Okay, but the same ACP published Growth Theory of Digital Dental Terms. But in this literature, they are still using the digital impression in common. So it's confusing, but I think it's better not to use the digital impression instead of intraoral scanning. Okay? We have many advantages when we use the digital. Easier to communicate with the dental technician and also for the patient. And also, it's easy for the standardization, and it's good also for the record preservation. So we have many advantages when we use the digital, right? Okay, so this terminology is very important. The cloning is not like a copy or paste, right? So you make exact same data when you use the digital in your office, okay? Here I'm gonna start with my favorite case, okay? A lady came for change number 21 to 23, so left anterior 3-unit bridge, because she can feel some cement wash out, right? So I explained many things, but she just want to change it, the anterior 3-unit bridge. So this is it, right? From 21 to 23, okay? I removed it, and I temporized, like this, in the upper picture. Then, after that, I sent the case to the lab, and my lab technician made 3-unit zirconia with the porcelain-fused zirconia bridge for this patient. Well, I tried in patient mouth, and patient accepted for cementation. So I cemented. But 3 hours later, patient came back to my office, and she was complaining about the shade of the tooth. In the middle part, it looks too white, and the translucent zone is narrower, shorter than the adjacent number 11. So I look at it, and I agree to redo this case. At this point, what you gonna do? Right? So you can call the lab and call to the lab technician and told him to do it again as patient want, or ask lab technician come over your office. Well, this is what I did. I called the lab and asked him to open the previous design file. So this is what it is. As you see in the middle, there's a too small room for the veneering porcelain, and also on top of the on top of the area, there's a too small room for translucent porcelain. So this is what it looked when I cut the tooth out from the patient mouth, right? So we don't have room for porcelain, and we don't have room for translucent porcelain as well. So I decided to go over and do it again, and this is what I decided. So I changed the design, framework design. I give more room on the middle part. I give more room for the translucent porcelain on inside the teeth. So I got new processes, new restoration. I delivered and tried and delivered in patient mouth. So can you notice the way of communication is easier than before, right? So using digital have advantages. And recently we have big changes. What we used to use for digital dentistry was the milling machine. But right now we can use the 3D printers, right? So that makes big changes like this. So milling to 3D printing changes, we can use digital dentistry not only in fixed, we can move to the removable part, and also we can use simple changes, just do like a traditional way, change it to the new way. No, we can use the typical protocol for only possible in digital area. But still, we have to be careful about 3D printer, because 3D printer can harm your lung, right? So from the Canadian Occupational Health Center, they are summarized like this. So we have to think about those respiratory symptoms like asthma, headache, and the skin problem like this. So though for workers use personal protective equipment, PPE is so familiar these days, right? So PPE you must have for if you want to use the 3D printers in your office. So that's the caution that if you want to use the 3D printer. Okay, so what we used to think was if we're doing something digital, or if you if you want to make some restoration by CAD/CAM, that means final restoration could be zirconia or any other monolithic material, or if you're applying in an implant, it has to be the custom abutment. But in the 3D printer era, it's not true. So we can use anything. So let's give you the simple example. Okay, so this is the single crown case on a lower premolar, and I use my intraoral scanner, which is i500 from the Medit, one of Korean company. Okay, and I made it faster. Okay, so this is the way I do the natural dentition scan. I scanned briefly, then I remove the margin and I do final scan. So I have data like this, right? Then I send the case to the lab, and my lab technician started design. Before he did anything, we made the model on the model builder and printed. Okay, and he designed the cupping and also full contour as well. So he made 2 STL for final restoration, right? So first thing he did was he printed the full contour and he did the casting. So now we have metal crown, right? And the second, he milled the zirconia, so we have monolithic zirconia crown. And with the coping design, right? And he printed and he cast it. Now we have PFM coping, and we use the 3D printed model as a reference. So he built it up the porcelain. So now we have PFM crown. So the last thing we did was he milled the zirconia coping and he built it up the porcelain on top of the printed model. Now we have PFG crown, porcelain fused zirconia crown. So with the 2 STL, we made 4 crowns. It's possible because we have printed model, right? So we have metal crown and full zirconia, monolithic zirconia crown, PFM and PFG crown with the same data, right? So as you look at it, I tried in the patient mouth 4 different crown. Each one looks good, and patient choose PFG crown. By the way, if you look at the workflows, monolithic zirconia crown is the only full digital workflow. So other works, we need to work with lab technician, right? So lab technician has to do something by their hands. So these all 3 are Digilog workflow. Maybe you can call it partial digital workflow instead of Digilog workflow. So I named the Digilog workflow mixed with analog and digital workflow. Okay, now I'm going to show you the digital workflows in implant restorations. So this is how I divide. So traditional is like a conventional workflow. And Digilog is mixed with traditional and the digital workflow. So here, last digital is the digital workflow. And also depends on the material or if you have a model or not. Okay, I named the elastomer-less and model-less and gypsum-less. So if you do it elastomer-less, it's going to be Digilog. If you do it model-less, it could be digital. And gypsum-less could be Digilog and digital as well. Okay, so I'm going to briefly explain what I have for these different workflows. Okay, let's go back to 2006. Okay, so this was 2011. I'm sorry, 2011. And this was actually my first case to use the intraoral scanner for the dental implant. Here I have number 16 implant right here. Now I connect the healing scan body instead of impression copying, and I use my first intraoral scanner. I used to have a iTero intraoral scanner. As you know, this is like not the video late scanner. This is the photo stitching type scanner, right? So I made it 4 times faster for encoding. So I'm keep taking pictures of my patient dentition, right? Okay, so after I took several more pictures, I got the data, I sent the data to the lab, and my lab technician designed the custom abutment. And also, he milled the model of custom abutment. So on top of this model, my lab technician did do wax up and casting and build up the porcelain, and he made a PFM crown, so settled metal crown. And I tried in patient mouth and I delivered. Is it really digital? So I didn't make impression. I made intraoral scan, but all other than that, so all other works are not in digital, right? So this is something I'm calling Digilog workflow, only in elastomer-less Digilog workflow. I think this is very primitive digital workflow. Okay, a few years later, I have a dental implant on the left upper with the sinus graft, like this. Okay, then I connected at the time when I made impression. I connect the scan body like this, and I use a Trios. I think this was Trios 2. Okay, I made intraoral scan for this case, right? Then I have data now. So we use the data for design the custom abutment and splinted monolithic zirconia crowns, right? So I designed the custom abutment and the prosthesis as well. And my lab technician milled the custom abutment, also milled and sintered the 2 splinted crowns, okay? I don't have model for this case, right? So this is modelless. And when the patient came back, I assemble custom abutments and the zirconial restoration in patient mouth. It did very well. It goes very well. So I was very satisfied with the modelless workflow for implant dentistry. Okay, if you have a 2 or 3 implant adjustant implants, that may work with model-less, right? So this I'm calling model-less digital workflow. Maybe you can call it full digital workflow, right? Okay, so third workflow. So this is a recent case. So I have a single implant here, and I scan the scan body, and I have data, and my lab technician designed custom abutment and the crown, but at the same time, he printed model. Okay? So before patient come, I have model, at least I can check the proximal contacts and the occlusion, so it reduces your chair time. Okay? So what is the most expensive one you have? That's my chair time. That's my working time. So time in my workplace and my office is precious, right? So I'm using more like these cases. So still you can call it full digital workflow, but I'm calling gypsum-less digital workflow because I'm using the model that's not made from the stone. I use the model that printed. So this is how I divide my workflow. So in the office, when I send the prescription to the lab technician, I'm writing down model-less digital workflow or gypsum-less digilog workflow like this. That's how I divide the workflows. Okay, let me introduce one of other patients. Okay, so it was done 2012, right? So patient needs some implant on the upper dentition. So I place like 5 implants with the sinus graft on both posterior maxilla. Okay, and this is initial picture at August 20, and I placed implant 2 days later. Okay, let me introduce my patient. Mr. Olivier is from Geneva, Switzerland. Okay, he came twice to Seoul. Like one for the implant placement, the other for the implant restoration. Okay, so I don't know. You can hear his voice. Can you hear his voice? He came twice to Seoul for implant restoration, right? So let's skip this video. But I'm working with my own lab technician because I have my in-house lab. But it was not easy to make a restoration in a week. Because you have to do the uncovery like a second surgery. When you connect the healing abutment, you have to wait for healing, right? When you make impression immediately, then you have to choose the abutment and you have to adjust the abutment, then start to do the wax up and things, right? So it was not easy to handle everything in 10 days at his second visit. So I was thinking, what we do after we place implant, we do nothing, right? When we're waiting for the osseointegration, when we're waiting for the soft tissue healing, we do nothing. We just wait until it heals or until it sticks to the bone, right? So I was thinking that can we use those period of time that we're waiting for the making restoration, okay? That's how I started with the new treatment protocol, okay? So here I have a patient. Number 47 has a root fracture, so I had to extract the tooth. So this is a periapical radiograph. Even I'm a oral surgeon, it took quite long to take out all this tooth because it's root canal treated and the roots are very narrow and slender. So it spent like an hour to taking out this tooth. So I decided not to go for immediate placement for number 47. So I waited 2 months to place implant. Okay, so after 2 months, when patient came back, I opened the flap, I placed the implant. Immediately, I get the initial stability of my implant. Before I do the bone graft, I scanned with the scan body, right? Then I finish the bone graft and I cover with the healing abutment and I send the patient to home. Okay, this is a radiograph after implant placement on number 47. Okay, now I have a data of dental implants on number 47. So while waiting for the osseointegration, I sent the case to the lab. I asked him, my lab technician design the custom abutment. Okay. Then he made the PFM crown on top of model that milled of custom abutment. Okay. So when patient came back, like 2-3 months later, okay, simply I did was I removed the healing abutment, then I connect the custom abutment and I cement the crown. Okay, so I don't have prosthetic visits for this patient, right? So if you think about prosthetic visit, start with the removing healing abutment and placing impression coping or scan body to start the restoration, right? But I did my lab work while I'm waiting for the osseointegration, okay? Right, so I don't do this for all of my patients, but I do this often when patients come from far away, patients are busy, then I'm trying this protocol. So simply, there's no prosthetic visit, only you have delivery, right? Because you made impression way before way before the osseointegration happened, right? So this is a clinical picture at the delivery, okay? Have you heard about the in-coat healing abutment, which was from 3i Biomed, like long time ago, about 2007 or 2008, right? First time when we came out with the in-coat healing abutment, they made the silicone impression and they locate the lab analog by drilling by robot arm on the model, on the stem model. Okay, so this was first publishment about the in-coat healing abutment. That was 2006. I'm sorry. Okay, so that's they call a novel workflow. Well, but if you look at it, there's nothing too much change. You still have to make impression, right? So also there are errors when you use the in-coat healing abutment. But by later, they've changed it to the digital. They have MOU with all the different intraoral scanner companies. Now it's better because you can make impression anytime, right? Here, we came up with a new idea. Because when you scan the healing abutment, when you matches the data to the library, you will see many errors. Because of the angulation. When you match the library data to the actual in-coat healing abutment data together, we have more errors because the healing abutment length is very short. So the idea comes from those errors. So we want to try to make it longer and taller. So that's why we come up with the 3-piece in-coat healing abutment, right? So this one, you can use it as a healing abutment while waiting for the healing. And this one, you want to make it, when you want to scan, you can make it longer of healing abutment, right? So I tried in the model. First, I placed 2 implants on the model. Then I connect the scan pin, make it taller, like this. Then I scanned, like this. At this time, I used the Trio 3. Okay? Then I send the data to the lab, because my lab technician has the in-coat healing abutment data on his CAT library. So he designed custom abutment and zirconia crown, splinted zirconia crowns. Then we tried on the model, and also we tried on actual model. And it really did well. Okay? So from this picture, this is the picture right before we scan the in-coat healing abutment from the Neobiotech. Okay? You just simply connect the scan pin, make it taller to reduce the angulation errors when you match the in-coat healing abutment in your CAT software. Okay? Here, I want to introduce another patient who lives in Japan. Okay? So she's Korean, but she married with the American, doctor who worked in the US Army in Japan. So she says she can come Korea often, but she cannot stay too long because she have to take care of her daughter. So you're in the right place and right time. So I decided to place 2 implants on the right lower posteriors. So I did the guided surgery, like this, but I opened the flap because I knew from the beginning I'm gonna need the bone graft. I'm gonna need the GBR for this implant, right? So right after I place the implant, I connect the in-coat healing abutment. I did bone graft on the buccal side, and I close the wound. Well, a week later, when patient came back for the stitch out, I simply scan the scan pin on top of my in-coat healing abutment. Okay, then I started scan. At this point, I used the i500 from the Medit company, the intraoral scanner. Now, I got the data, right? So I send the data to the lab, and my lab technician used the in-coat healing abutment library, and he simply designed the custom abutment and the zirconia crowns, split zirconia crowns, and we checked occlusion and proximal contacts on the printed model. Now, so we are ready, right? So when patient came back from Japan 3 months later, she cannot stay too long, right? So when she came back, to my office, right, I removed the healing abutment, in-coat healing abutment, and I connect the custom abutment, right? And I tried in the zirconia crown and adjust it and cement it in single day, right? So this is the way we can reduce the prosthetic visit for the patient, okay? So scanning you can use a prefabricated abutment, scan body, or coated abutment, right? So scanning of in-coat healing abutment gives you the freedom to load the implant. So it gives you anytime impression. That's the biggest advantages you have. Maybe you can have disadvantages as well. Maybe you need to have more components on your stock when you're in your office. So that's another bad thing. But good thing is you can make impression anytime. Okay? Well, I used to present it in the intraoral scanning and the ICI World Congress. It was about 2011, right? That time, my chairman asked me what's the disadvantages using intraoral scanner for the dental implant. So my answer was you cannot use the prefabricated abutment. You have to have customized abutment. But that's not true for these days. This is an article that published in JPD, one of my colleagues, Professor Jong-Yub Kim from Yonsei University. He used the prefabricated abutment, and he simply scanned like a natural dentition, right? Then he made a zirconia crown on top of prefabricated abutment connected on the dental implant and patient mouth. Okay? Well, what if some margins are deeper in the gum? It covers with the gum. What's going to happen? Well, we don't have to retract the gum in this case because we have prefabricated abutment library data on the library. So we can call those data over web to see the margin clear, right? So this is good because you don't have to have a component, right? This is maybe cheapest way to make a digital crown for the implant, right? So when I see this, why not in other method? Okay, so here I have a patient who need to place implant number 37. Okay, I placed it, and this is a radiograph, and I took impression. I simply use the in-coat healing abutment and I scan the model. Okay, before I go for the intraoral, I scan the model on the model scanner, and I choose the prefabricated abutment from the library. Then I made the zirconia crown on top of it. I tried it worked. Okay, so if it worked, why not in using the intraoral scanner? So here I have another case. This lady needs the single implant on number 26 and the immediate placement with the sinus graft with the crestal approach. Of course, but I use the SCA. After that, I scanned this case with the intraoral scanner. I sent the data to the lab. So what my lab technician did was he chose different curves, he chose different length of the abutment, and finally we picked one abutment, prefabricated abutment from the library, and I ordered that prefabricated abutment, and my lab technician design and fabricate the zirconia crown on top of what we choose. Okay, so here is a prefabricated abutment. I didn't touch, only I did sandblast on the abutment area for better cementation. Okay, and there's a monolithic zirconia crown we made. Okay, this is what we did. Okay, from now on, I'm gonna show you the interesting cases that I'm doing for these days. Okay, here, patient came for the laminate veneer crowns for the upper anteriors, right? As you see, patient had pegoratellis. Okay, right here. Okay, pegoratellis on the left incisor, and this one is the dense invaginatus. Okay, as you see here is the periapical regions, right? So first thing I did was I did have to do the caries control and the root canal treatment for some tooth, right? Then I made the first set of data, like the upper and lower dentition. Okay, so another thing I did was I duplicate upper and lower data. Then I started soft tissue around like an oral cavity. So I'm calling perioral facial soft tissue scan for diagnosis. So as you see, so for upper dentition, I'm attaching upper lip and nose. From lower dentition, I'm attaching lower lip from the lower dentition. Now, I finished the data like this. So upper to upper soft tissue and lower dentition to the lower lip, right? Now I have two sets of data like this. So full dentition and dentition with the soft tissue around the oral cavity, right? So from here, my lab technician started design temporary restoration for this patient, right? Then he printed the provisional restoration for this patient. And after I got the provisional restoration, I prepped the tooth and temporized. Of course, I have to scan again. So at this point, I scan only upper because I don't have to have lower because I'm calling data from the duplicated data. Okay, so I send the data to the lab, right? And the lab technician collect the midline first, right? Then he designed from my final preparation scan, right? Of course, he can use the soft tissue because all the posterior teeth are same. So it's like overlapped, and he's designed the veneers and crowns like this. Even you can see this one, number 11 and 21 is crooked like this, right? Then he corrected. Even you can watch it from the lateral profile. So what I did was instead of milling all the restoration, I asked my lab technician milling the wax, and I use the pressable ceramic because that's my favorite, right? Then I cemented, tried, and cemented in patient mouth. So if you divide workflow, this is gypsum-less digilog workflow. But if you milled all the restoration, then you can call fully digital workflow, right? So it depends on what kind of final restoration and which method you use. You can call different way. Okay, here I have another case. This young gentleman need some veneers because he want to close the spaces between his anteriors, right? So this is what I did. So I did scan first for upper and lower dentition first. And as previous patients, I scanned soft tissue as well. But at this point, I tried to scan the face, more face, because I'm gonna need the midline, and I just wanna see the eye lines as well to see the horizontal references and vertical references. So I'm calling T-zone scan. As you see, I'm starting upper soft tissue scan from the upper dentition. I started nose like this, and I marked on his face to see how it goes, right? So I marked the midline before I scan. So this is the result. So this is patient, and I marked midline, and this is scan data. I did same, and I did the final preparation. So one laminate veneer, another laminate veneer, and partial laminate veneer with the preparation for number 22. Okay, so this is the initial data, preparation data, and final restoration data. Yeah, I did same. I asked my lab technician print the not print, and mill the wax, and we did the pressable ceramic for the final restoration. Yeah, I tried in, I cemented. So if you divide the workflow, what is this? This is, again, same as digital workflow and also gypsumless because we use the model. Okay? So new entry to the digital is fun, right? So it gives you excite with the new things and different ways what we used to do, right? Okay. So I'm very happy and use new digital in my house. Okay? Because I have digital piano recently, not recently, from last year August. I'm using digital piano. It's interesting because you can have tons of instruments and you can do a lot of things. You can record and you can, mix, and this is very funny thing, right? I don't know, can you hear this music? Okay, I play piano and I found it's interesting because you can change the instruments every time. It feels different, right? I'm playing piano. I can play digital piano because I know how to play like a conventional, traditional piano, right? So, I want to summarize my lecture today, my presentation today. We have big changes, recent changes in restorative and implant dentistry due to the digital technology, right? It's very interesting, but still, understanding fundamentals and principles that we learned from the school and textbooks are still important because we have to know the origin, right? So digital dentistry is a modification, right? So because modifications comes from conventional or originals. So that's how I summarize to this. You can use digital for the new protocol, right? But still, you have to understand conventional or traditional workflows. So that was it for today, and thank you very much for your attention, right? Okay, so I'm waiting for the question. 질문이 있나요? Okay, I know you guys are busy to do something, like maybe in workplace or maybe in the rest in your house. That's why you don't have question, right? Okay, how was it? Okay, before I want to close, I want to ask you to subscribe this channel.